going to talk to you more about some of the more direct interventions. So rather than working to manipulate the environment or the learning situation, some options of actually working directly with the particular child or these are services that can be provided by either the audiologist or the speech pathologist, because we're typically not dealing with insurance in this case, because a lot of these are services that may be provided in the school setting. Both the audiologist or the speech pathologist can provide it. Typically, audiologists are not reimbursed by insurance plans to provide oral rehab, so it typically falls to the speech pathologist if insurance is going to be involved, but because a lot of these services are typically not insurance reimbursed, we go ahead and can provide it. If the child is an infant or toddler under the age of 3, the services are usually provided through the state early intervention program. All the states have to have one. And it's administered through funding, through federal funding under Part C of the U.S. Department of Education guidelines. It gets a little tricky because we did talk about how there is now this thing called family share, where if there is a situation where the family has access to insurance, that they're encouraged to allow this Part C program to submit charges to their insurance, but some people don't want that because it can count against their lifetime caps, and so they choose not to allow the insurance to be charged, then they have to pay a sliding fee. Once the child reaches the age of 3, they're going to transition over to public school services as they're administered by their local district. And they're eligible for those services until they're 21. Now, a lot of times the district may not feel that they're equipped to handle whatever special services the child may need, and so there are cases where the local district will actually grant a waiver and allow the parents or the family to obtain these services elsewhere at their expense. So I have seen some kids in the past where the local school and local district didn't feel like they had adequate resources to meet that child's needs, and so they would actually pay for some services where I was working in the clinic that I was working. That's not commonplace, but it's not unheard of either. Parents are also free to choose to pursue those independent private services in addition to whatever is provided at the school. And when we're talking in terms of what do we do, just as we've mentioned, we have a lot of options that we can choose in terms of what type of intervention are we going to offer. Are we going to make it a completely auditory oral? Are we going to use total communication? Is it going to be manual communication? Is it going to be provided as part of a residential program? In the mainstream classroom, maybe a collaborative type of approach? Are they in a self-contained classroom for hearing impaired children? So lots of different options, things that we need to consider. When we're considering an auditory verbal method, and I put up here some skill areas that we would probably want to work on and how we would go about that. The outline that I provided is based on Pollack and Lang. Those are the two researchers who have developed kind of time-tested approaches to auditory rehab for children that have become become kind of the benchmark that everyone judges by. And so what you want to do is look at what does the child need? Where are they having specific problems? So that's the skill area. And then you need to come up with ways to facilitate their responses. So for example, at a very basic level, are they having trouble? Maybe they have had hearing loss and they were later identified. We know that in some cases kids are later identified, despite our best efforts. So they had some auditory deprivation. They may not react and respond to sounds the way that a typical child would. And so what we want to do is build or facilitate their ability to react and respond to sounds so they can indicate whether or not they're hearing it. And a lot of times that'll be done with noisemakers or anything, toys that make noise, those little plug-in, there's dogs that bark and walk and wag their tail, and there's a little monkey with the cymbals and all kinds of things. So you use things that generate a lot of noise, all those things that as a parent, you're like, please don't give my child that. And it usually comes from a grandparent. They smile as they do it because, it's going to get your house, not theirs. But anyway, so that would be something. Maybe you're working on sound localization. We've done some fun things where you kind of have the child blindfolded, and you have you move around the room and make sounds, and they have to turn to figure out where the sound is coming from. Localization is a skill that I think is grossly under-recognized in terms of its importance, and I'm not really sure why that is, but I very seldom see clinicians addressing that. Why is sound localization an important skill? Why would we give a rip if a kid can localize where sounds are coming from?
Communication is someone's talking to you, localized surveys instead of tuning out other things.
It's very much involved in that selective attention, active listening. They need to be able to tell where sounds coming from so that they know where to focus their attention. Absolutely. Another aspect.
I was going to say for safety.
Absolutely, safety is very, very important. If the child is going to be outside, they need to know where sounds are coming from because they need to know, or even if not for safety, from a practical standpoint. Let's say the child is participating in a sport, and a teammate, calls out to them, I'm open or whatever. They need to know where is that sound coming from so that they don't kick it to the opposing team, for example. We had a kid that played soccer with Will a couple of years ago who was hearing impaired, and it was so hard for him because he really had a difficult time telling where sounds were coming from. And so they tried to come up with some hand signals so that if he saw a kid make a certain gesture, that they would know that he was open. The unfortunate thing is everyone else can see that too, and it didn't take long for the opposing teams to figure out the hand gesture and knew, okay, attack this kid because the ball's coming to it. But in any case, over time, his sound localization skills did get better and it got easier. It's a challenge. If you can tell where sound is coming from, it's going to be hard for you to really tune into and focus on.
Does it matter if they can localize sound so that they can see them?
That's
they can look
another very important aspect. If you are promoting or addressing the use of visual cues, that's extremely important. You need to know who's talking. Imagine in a group situation, if you have trouble hearing, you may have a real difficult time figuring out who's talking. And yet, you may, be in close enough proximity to get a lot of visual cues, but if you don't know who to look at, it can be difficult. And some of the activities that you can do for sound localization are pretty fun. You have people giving directions while they're blindfolded so that they're only getting the auditory image. You ever watch Survivor? Usually they have a challenge where there's a group of people that are blindfolded and someone's calling out directions and so you can actually get some pretty fun activities out of that. Maybe you're working on auditory discrimination, and so you can start off with closed set stimuli. Do you know what I mean when I say a closed set? Where the child has a known set of choices to choose from, so that maybe you're working on final consonants, being able to discriminate final consonants, and so you might have minimal pair words, like cake, cage, cape, cane. So we've got the p, k, those sounds, and so you have those, maybe sitting out on a card, the particular sound, and then you present the kid with a word, and he has to identify which ending sound did that word have. And that's a really good way to work on speech reading as well, if you're allowing and promoting visual cues, because if you look at those, watch me say cape, cane, cake, cage. They look, at least the velars and the bilabials look really different. So immediately, if they're getting good visual cues, they probably increase their chances to at least a 50-50 chance of getting it correctly. And then if you embed it into context, so that rather than just as random single words, but you start putting it into a context, then give like a carrier phrase, bring me or I need, then they can sometimes they'll do better in that kind of a context. Does that make sense? So you may have to start off with a closed set where they kind of know these are my potential choices, and then you can gradually either expand the set or make it open-ended where they have to actually identify without any cues. It could be something really simple though. Discrimination could be just as simple as are two sounds the same or are they different? You say pa, is it the same or is it different? It's interesting because once kids really start those listening skills, they tend to overgeneralize, and so we have. Do you guys remember what an allophone is? Back in phonetics class. What's an allophone?
Variation of something?
It's just a variation of sound. Absolutely, bravo, good job. And so, for example, the sound in pop is different than the p sound in clip. The clip tends to be more aspirated. Well, a kid with hearing impairment may actually, if you said, I'm going to say 2 words, well, you tell me if the ending sound is the same or not. So you say pop, clip. You all are going to say those are the same, because it's the p sound. But they often are very concrete, and because one is aspirated more than the other, they may actually say those are 2 different sounds. And so you sometimes have to work on helping them realize that you can have a slight variation in the sound in those allophones, and yet it's still the same sound. Okay, so discrimination. Anyway, I'm not gonna belabor it and go over absolutely every one of these. I just want you to kind of have it laid out, something that you can refer back to. So the auditory verbal method is one that primarily they're going to focus on those listening skills. Someone like me who tends to want to do a more eclectic approach, I'm going to offer them access to visual information just because we all use it, and I don't think that I should hold my kids who can't hear well to a higher standard than I would, someone else. Okay? All right. Another method that's fairly widely used is what's called the verbotonal method, and Guberina is the researcher that's most closely associated with that. It was actually a method that wasn't originally designed for use with children with hearing impairment. It was actually a strategy that they used for children who were English as a second language or emerging English language learners. And some folks, some researchers in the area of auditory rehabilitation observed this and said, ooh, some of these strategies might be really useful for our kids with hearing loss. And so they set up some satellite programs, some pilot programs at Ohio State, at the University of Tennessee in Knoxville, and in the Miami-Dade Public Schools. And it is very much an auditory focus approach, but rather than relying on visual cues, they rely on vibrotactile cues. And what's really cool, and this is really, really old school, because it was something that we did back when I was in school. Have you guys seen an auditory trainer, like a desktop auditory trainer? Basically, it's a box. It's an amplifier. Now they've gotten very, very small, but and then the kid has some sort of a headset or earphones, and so basically it's like an FM system, but rather than using FM, they're hardwired to the device. And the verbotonal method, you actually can use one of those, but then it's got a plug-in, and it looks almost like a mouse, like a computer mouse, and the kid can rest their hand on it, and as the person talks, it vibrates in time with what they're saying, so that you're getting the prosodic information, you're getting that kind of rate and rhythm pattern, and anyway, they incorporate things like that. It does allow some limited visual cues, but the emphasis is more on the auditory and vibrotactile. It has been successful. It's an intensive program, 3,000 hours of instruction that's done in group and individual sessions. So it's not something for the faint of heart. You have to have a family that's really committed, because when you consider that 40-hour work week, typical 40-hour work week, that equates to 2,080 hours a year. Okay? So if this is 3,000 hours, obviously this is something that is going to take a long time and a major commitment to finish. So if you are interested in becoming a provider, or at least learning the strategies, then you actually have to go and receive training just outside of Knoxville, Marion, between Knoxville and Gatlinburg. So fun trip. But you can actually then get trained in providing this method. I'm not convinced that most of patients I've ever worked with would have the stamina or the wherewithal to stick with a program that's 3,000 hours. But I do think that getting the training for professionals is worthwhile, or at least becoming familiar with some of the methodology, because I do think that it can give you some good information. I've done, and some, not even, although I have used the tabletop vibrotactile device, you can do it with just with hand touch. You can have them, touching, to the laryngeal area and get that same feedback. And so then they try and replicate what it is that they see you doing, hear you doing, and feel you doing all simultaneously. And so it becomes a very multi-sensory approach. Like I said, I'm all about giving the kid everything that they need to be successful. And so I'm all about combining multi-sensory approach. But I'm also a Montessori dad, and I'm all about give the kid the opportunity. Kids don't learn from sitting there in a seat being lectured to. Kids learn by hands-on, by what they see, imitating their peers, interacting and engaging. And I think that's important to try and include in our therapy.
For that 3,000 hours, is there like a duration? Is it a year? 3,000
Oh no,
hours
it's
in a year?
more than a year.
Okay.
It's going to be going on for at
It's
least
just 3,000 hours total. It's just 3,000 hours total that you're done.
Yeah, because if you figure, like I said, not the average, when a person is employed, quote unquote, full time, they're working 40 hours a week, that's based on 50 weeks a year, 2 weeks vacation, or 2 weeks of time off. That's 2,080 hours. So that's barely 2/3 of this. So you'd have to add, an extra how many months, 40 hours a week to get that done. That's just crazy. So it's going to be spread out over. Okay. Question. All right. Another method that's often used, that's an auditory or primarily auditory approach, is the Erber method. And what it does is facilitates, if you're familiar with the Kaufman approach, the successive approximation approach for apraxia, where you work on progressively closer approximations to a target. That's sort of what this does, is that you go through a series of stimulus response paradigms, so it's a very behavioral approach. And so the first phase is that you work on detection of sound. And you work first with individual speech elements, and then you expand to the syllable level, and then you work at the word level, and then phrase, sentence, and then finally connected discourse. And you're just working on detection. Then you work on discrimination. Same and different. And again, you take it through that same paradigm. You start off with the individual speech sounds, you move into syllables, you move into words, and so forth. Then you actually work on identification. So you go from, is it there or not, to, is it the same, to, what is it? You actually label it. Oh, that's the sound, or oh, that's the sh sound, or oh, that's the g sound, okay? And then finally, you work on comprehension. So you work on attaching meaning to it. I liken it to, if you think about the traditional approach to articulation therapy, where you work on all of the individual speech sounds in isolation, then in syllables, then in words, in all the different positions of words, initial, medial, final, then you work into phrases and then sentences and finally conversation. This is sort of the same thing, but it's taking it at the level of hearing. Okay? certainly not something that is going to be accomplished very quickly. It is going to be a fairly time-consuming approach, okay? So just be aware. But it is very effective, and so a lot of people use it because it's another one of those tried and true things that has withstood the test of time. As far as some indirect interventions then, again, you can provide that classroom consultation, those participation in collaborative teaching teams, and you can do your observations and then try and promote additional environmental modifications. All right. These are the approaches that I tend to like, eclectic approaches. They're ones that allow you to take bits and pieces of other things that you like and combine them effectively. So typically, these are not approaches where you could go and, like the verbotonal method, and go and get trained to be certified to do it. Now maybe you get verbotonal certification so you learn some of those strategies, but then you're going to combine it with some other things. Maybe you'll do some more traditional polygon ling type stuff. It's totally up to you. So basically it's a mix and match. So you as the clinician get to choose. I always tell students that speech pathology is both an art and a science. The science is understanding the anatomy and physiology. It's understanding the etiologies and the pathophysiology of the different conditions that we work with. It's understanding the implications of if the person has a hearing loss, the type, degree, and configuration of their hearing loss. How is that going to impact their access to sound? So how is that going to impact their communication? The art is then taking that knowledge and applying it and adapting it to your individual patient that you're going to see. So I am very much in favor of clinician-directed or clinician-structured interventions. So you can pick and choose. Okay? The nice thing is there's no one standing over you telling you, you can't give them visual aid. Who are you to tell me I can't? It's my signature on these notes. It's my license that's on the line. If I say I want to give the kid, then no, I'm not gonna say I'm providing, so and so's approach. I may say that I'm using some of the strategies that you would find in that, so that if someone wants to know what am I doing, but that way I also don't have to pay a premium. I don't have to pay some sort of a residual to them because I'm, advertising that I'm using their approach. I get to decide, and I kind of like that. Okay, so you can use any or all. If it works, you do it. If it doesn't, you try something else. You've heard me say that before. Another approach that is fairly famous, probably because Helen Keller is, right? Who she was. She's no longer with us. Anyway, she was a woman who was born both deaf and blind. If you've ever read the book or seen the movie The Miracle Worker, it chronicles her ability or her experience in learning to speak. And her teacher was using the Tadoma method. And the Tadoma method was developed at the Perkins School in Massachusetts. And Al Horn is the researcher, the clinician who developed it. and he had two students that he was working with that were both deaf and blind, Tad Chapman and Evelyn Simpson. And so he came up with these strategies that combine tactile cues and hand and placements for sign language, and was able to teach these kids. It's a manual / tactile approach. He was able to teach them sign language and to communicate using this method. So you need for them to know that. Someone has already requested to do their treatment approach. I'll be excited to hear more about that. But it's a great approach. Again, I know what it is. I've seen it done. I'm not fluent in sign, so it is not an approach that I would be providing. It would be something that I might refer them to a colleague to do, because that's, I know basic kid signs, for language facilitation. I know milk, I know pretzel, I know cracker, I know cookie, I know more, I know go, I know dog, the simple little vocabulary items, but to converse, can't do it. My son always makes fun of me when we go to the hockey games. They have this word thing, some dental group, they show a hockey player getting in the mouth and his teeth fall out, and then there's 3 teeth, and they've got the logo getting under one, and then they move around, and so you have to try and follow it to figure out, and after about 2 seconds, I'm like, okay, I'm done. I have no clue. I'm just, that active visual movement, I can't keep up with it. It makes me dizzy. So, anyway, the Tadoma method for dual sensory impairments, when they have both visual and auditory impairments. Okay? Another area that I think is grossly under-recognized is auditory processing disorder. You guys, particularly if you work in a school setting, are going to be encountering and getting referrals from more and more kids who have auditory processing problems. And along with them comes their 504 plans, because they don't qualify in most places for an IDP. Unless you move to certain states, in which case then they do. But in any case, these kids are really, really going to struggle, because what's the primary complaint that we hear from folks with auditory processing problems? Difficulty understanding in noise. And what is the average classroom? A noisy environment. It's not quiet. So these kids are going to struggle. And it's really not doing anything amazingly different. Anything that we've already talked about in terms of approaches is probably going to be appropriate and useful for kids that have auditory processing problems. You just have to focus on what are the skills that they need to develop. So you might work on vocalization. You might work on sound discrimination. You might work on the sound pattern recognition, so that they can get those nonverbal, those prosodic cues, those inflections and intonations. The good thing is they can hear, but they may not be able to recognize those. The kid has temporal processing issues. What aspect of language do you think they're going to struggle with the most, or aspect, maybe? Temporal processing is that ability to recognize sounds and their patterns. Things like durational cues, pitch cues. So what do you think you might have trouble with?
question or if it's a statement?
Yeah, figuring out, was that a question or was that a statement? What else?
I don't know, like, this kind of is intonation, but like sarcasm, things like that.
Bravo, absolutely, yes. They are very concrete. They don't get sarcasm. They don't get humor. They have trouble with inferences. They can't, kind of listen between the lines rather than read between the lines. And they, if I say to you, how good your inference is, you're driving a bus, and at the first stop, 3 children get on, 2 boys and a girl. At the next stop, 2 boys get off, and 5 adults get on. You drive a little further, and all of the kids get off, as do 2 of the adults, and an elderly woman and an elderly man get on the bus. Who's the bus driver? There you go. A child with problems with inferencing, a child with temporal processing is going to have missed that I've already said you're driving a bus. And so you ask them that, they're tuned in so much to it. As are a lot of people.
So
and so you get this awkward question of who's driving the bus, you're like, well, I don't know. You, I said, you're driving the bus. You get the idea. But those are the type things you can laugh about.
Yeah, I'm exhausted.
Duh, yeah, you did say
I'm like hungry
you're
too.
bus driver.
I had beat ups, but I'm like hungry again. I
So
know.
then what happens?
They had $3.
They don't get
I
humor.
forget what kind of beer.
They don't understand if someone's making a statement or asking a question. What happens?
I ate a hot dog this morning.
They get confused.
So
They get made fun of because why? They don't necessarily respond appropriately. So their pragmatic skills are dramatically impacted. Those social communication skills. These kids can have a really rough time. Another critical thing that we find children who have problems with temporal processing, they have very poor music appreciation. A lot of my kids that have temporal processing issues when I do their assessment, mom will tell me they absolutely cannot stand music. They don't like the radio on. They will not, use an iPod or some sort of an MP3 player. They have to wear earplugs if they go to church or something where they know there's going to be music. The kid just doesn't tolerate it. Now, not every kid is that severe, but I've also had them say that, music's their worst subject. They really struggle to hear those differences. So temporal processing really is an important skill that we can't, I really don't think we can overemphasize it. So, typically you're going to be focusing, most kids that have an auditory processing problem, they have problems with degraded speech signals. So you're going to want to improve their ability to understand challenging linguistic information in challenging environments. So you may work on gradually increasing the amount of background noise, and they still have to follow the directions or comprehend the story or retain details, recall information that they've heard. You may work on increasingly rapid rate. There's some great CDs out there that have time compressed speech, where the child has to listen to and tell you what's being said when you're compressing or speeding up the speech by a factor of up to 60%. So rather than listening to Mother Sweat Floor, to Let's And they have to, I'm not doing this, with actual time compression, I'm just speeding it up, but these are digitally altered so that it does actually, using a standard predictable amount of increase of speed. And we know that some kids have a terrible time with rapid speech. So, and how often, and if you, for those of you who spent any time, observing in the classroom, how often does the teacher blurt something out quickly as there's chaos going on? Oh, don't forget that you need to do page 13 in your math book tonight. Johnny's head is spinning. What do I need to do? So again, working on that ability, so that you have multiple things going on. You've got reverberation, you've got background noise, you've got increased rate. Because typically what will happen is we work on one of those skills, we work on their ability to tolerate background noise. Or we'll work on their ability to understand time control, accented speech. And if any of you have taken classes with, maybe with, in one of the other departments where there's a TA who is a non-native speaker of English, and how sometimes it's very difficult to understand what it is that they're saying. I'm not slamming them, I'm just using it as an illustrative example. So we work on something like accented speech, or we work on time compression, or we work on background noise, or we work on reverberation, and we never combine them all together, which is what a lot of kids have problems with. And so it doesn't matter if you work on these skills individually, if they can't put it all together at the end of the day, they're really going to struggle. So you need to, yes, you need to work on those skills individually to get them to a certain point, but then you gradually need to start incorporating in all of those factors at once, or they're going to struggle. Okay? You might work on auditory decoding or auditory integration. What do I mean by decoding? Decoding something. What are you doing?
I don't really know, but is it like breaking it apart and like sounding it out almost like in a word?
Absolutely. Being able to take the sounds apart into their traits and components. Next time you say that to us, the third time you said that to me, oh no, I'm going to throw something at you. Thank you. The brave one, though, taking that chance, I'm going to have to give you a prize of that. I can always count on Taylor. No one else is going to raise their hand. You will do it. Thank you for taking a chance of being Chuck. I promise I'll never make fun of you for answering. Okay, so then integration. What's integration? Auditory integration skills. You're not allowed to answer. Yes?
Putting sounds together. And
Okay.
flipping.
And particularly where this might come into play is in group situations where they may be listening to multiple inputs and being able to kind of put it all together. That's auditory integration. A test that we do for that is the child with, we do, there's several, but one that's really popular is called the dichotic digits test, where the kid hears two numbers in one ear and slightly overlapped, not entirely simultaneously, but very close, hears two digits in the other ear and has to tell you all of the digits, all four digits that they heard. And you're right, it is hard. A little bit. But it's amazing how readily we do it. People that have typical processing skills, it's amazing. yeah, you have to concentrate. And so if you have any kind of attention problem going on, it can be hard if you're distractible or if there's lots of distractions, which imagine in a classroom, gee, it gets that little distracted. In any case, being able to take multiple inputs and make sense of it is basically what we're saying. Okay? That's why parents will say, stop, only one of you speak at a time, so everyone gets their turn and the parent can put together 3 different stories that they're being told about who just broke grandma's antique lamp in the living room. I don't know always at our house. I don't know. Will, mommy's at work, the dog's outside, I was in the kitchen doing dishes. Who did it? Will, introduce me to I don't know. Because I don't see I don't know. I see you. So you get the idea. We're going to take a lot of the same strategies that we would use for kids with hearing loss, but we're adapting them and applying them to these specific skill deficits. Some of the folks towards the back row who have had me for other classes, and they're just unfortunate enough to have me one more time before they get out of here in May, can tell you, I've said it in other classes and I'll repeat it here. A lot of what we do in therapy is simply modification of the same strategies, the same interventions, the same techniques, just tweaked to fit a different purpose. It's not rocket science, it's speech therapy. Okay. And I'm not down with it. I don't mean to imply, but it's one of those things where I think students, and Olivia's shaking her head, and I can pick on her because she used to be my GA, so I know she won't get mad. I think you go into some of your classes expecting that you're going to get these multiple pearls of wisdom and nuggets of practical wisdom on how to treat. If you're in a class on swallowing, there's going to be something very new and different here, which there are going to be some. But then you walk into your motor speech class and you're like, well, wait a minute. A lot of that stuff we learned in our swallowing disorders class, you're talking about here. Well, yeah, guess what? It's the same system, just a slightly different, we're talking about it in terms of speech output, not food ingestion. So maybe it's a reverse, but you're going to do a lot of the same things. So just understand that you're going to see some overlap, which is good because then it's less to remember because you've already learned it once, you just learn how to apply it. Okay? Questions? So, when we're working, particularly with speech skills for our kids who have hearing problems, but also with language, we have the same options available to us as we would in working with kids who don't have a hearing loss. We can do formal, kind of standardized or criterion reference, norm referenced or criterion reference testing, or we can do informal things, which would be like sampling, speech sampling. Okay? The problem that we have is that most of the standardized articulation and language tests that we have out there have not been normed on children with hearing impairment. So you're going to be comparing that child and their performance to that of someone who really isn't their peer. They may be age matched, but we're not going to be getting necessarily comparing apples to apples. And is that necessarily fair? Whereas if we have a test that has been normed and includes children who have hearing loss, I'm not saying it has to be a completely separate test that's only normed, but if we include children with hearing loss in those norms, I think that that's an important thing to do, because typically, if you look at the validity and reliability and the standardization and their protocol, they typically rule out and don't include kids with any kind of impairments. And yet we're using those tools as a gauge of the performance of kids who do have impairments. I'm the only one who's puzzled by that. Probably I am, but that's right. So, when you're selecting tests for assessing the communication of kids with hearing loss, if you have access to some specific instruments or formal test protocols that have been validated with children with hearing loss, I would strongly encourage you to do so. For articulation, probably one of the most widely used tests for children with hearing impairment is the Arizona Articulation Proficiency Scale, so the APS. You'll hear it referred to as the APS, that's what they mean. There is also a protocol, the Identifying Early Phonological Needs in Children with Hearing Impairment, so it's a phonological test. I'm an acronyms person, and I hate that something like the APS, I know, that's what they call it, and that's it. Try and come up with one for Identifying Early Phonological Needs in Children with Hearing Impairment, and you win a prize. How would you say that? I have no idea. IT Mitch. I don't know. That sounds like something that children should be exposed to. Then there is a protocol called Grammatical Analysis of Elicited Language, the GALE. I like the ones that have words that you can say, acronyms you can pronounce, so the GALE. The Sky High Language Development Scale is awesome. It was developed, I believe, if I'm remembering correctly, at the University of Denver, which kind of makes sense because they're a Mile High City, so Sky High. And what's really cool about that is it's not just an assessment of language, but it also has, then, depending on how the child performs, it has kind of a canned therapy approach, so it gives you specific goals to work on, specific targets. It comes in a kit, so it's got everything that you, it's like all in one. It's everything that you would need. So it's pretty cool. The Carolina Picture Vocabulary Test, so if you're going to do a picture vocabulary test, everyone and their brother, if you've gone through clinical methods, knows the PPVT, the Peabody Picture Vocabulary Test, or the Receptive and Expressive One-Word Picture Vocabulary Test, which are great. I like them, but they're not designed for use with children with hearing impairment. So why not get the Carolina Picture Vocabulary Test, which you can then use with all of your clients, including those that have hearing loss. Just saying, if you're in a position, this is Dr. Hahn's Pearl of Wisdom, number 312, if you're in a position to be acquiring materials, whether it be treatment materials or assessment materials, you want to get the ones that give you the best bang for your buck. If you're rarely to never going to work with a kid with hearing impairment, then sure, getting the Carolina is probably not something that you want to do. But I bet you're going to work with kids that have both phonological and articulation problems. So why buy an articulation test and a phonological test when you can buy the CAPS, the clinical assessment of articulation and phonology that does both? Then you have one test that provides you with information about both. And it's kind of the same way with anything. If you have a test for a treatment protocol or materials that are adaptable and useful with a broader population, you always want to go for that rather than something that's very narrowly focused, unless that's the only thing you're going to use. And then another one, which is great because it's a method of analyzing language samples. We actually have it here. It's SALT. Dr. Timler, in particular, is a huge fan of SALT. I am familiar with it enough to get myself into trouble with it because it's for the longest time I was working in early intervention, and so you don't really need SALT to do a language sample analysis of kids who are using 1 or 2 word utterances. Or I was working with kids that were nonverbal, so SALT doesn't have much clinical application or utility. So, but anyway, it is a program that you can use to analyze language samples. It was developed looking at language of both children with normal hearing and children with hearing loss. So it's a good one to have. And for those of you who know me, I am all about sampling. I love language samples. I love speech samples. I think they are the most representative indicator of what the child's communication is like. I'm all about language sampling. What's really nice is for the longest time, earlier in my career, most insurances require you to use some sort of a standardized test if you want to get reimbursed. Well, for people like me who are all about language samples, you're kind of screwed. Well, then when SALT came out, because it is considered a standardized assessment, suddenly now our language samples have much more relevance and meaning. So, anyway. There are a dozen or more assessments and checklists for auditory and listening skills, and all of them have acronyms that just roll right off the tongue. So immediately you know I like this list. The first one is the CHILD, which is the Children's Hearing Inventory of Listening Difficulties. And so it's a family-centered one. I've used this in early intervention programs before, where it's really designed for use with kids that are 3 and older, but I've used it with kids that were younger than 3. Anyway, it's a 15-item questionnaire, so the parents, based on their observations and interactions, you can also fill it out as well, because it's interesting sometimes to watch the family dynamic and see what the parents say and what you're saying. Sometimes they're not quite on the same page. Sometimes I feel like we're not even in the same book, let alone on the same page. But, another one that's really popular is the PEACH, which is the Parents' Evaluation of Oral Performance in Children. And then there's the TEACH, and it's the Teacher's Evaluation. And so basically these are checklists and questionnaires that look at how well is the child doing with their amplification system versus without. The TEACH is slightly shorter. The PEACH has 15 or 13, and the TEACH has 11. Another one is the DIAL, which is the Developmental Index of Auditory and Listening Skills. And it's a checklist. It's a criterion reference test. Have you guys used the Rossetti at all? Are you familiar with the Rossetti? I've seen some heads shaking. It's basically, it's an observational checklist where you sit down and you watch parent, family, caregiver, peers, siblings, whatever, interacting with the kid. And you get information about their social skills, their play skills, their cognitive skills, their receptive and expressive language skills, and their gestural skills. And you start checking off the things that you see and until you kind of start seeing a cluster of where are they seeming to be, but then maybe there's some gaps, so you start trying to elicit some of the behaviors. So you set it up and see, will Johnny protest if you take the toy away, for example. Or you can ask the parent, so you can get either, you get 3 types of responses. An observation, so you saw it happen. You could get an elicited response where you set it up and they were able to do it, or you can get a parental report where the parent tells you that yes, oh yeah, Johnny does that. He's adding at least a new word, 3 times a week. Okay, then I can give them hints to learn new words readily. I can check that off. Well, that's basically what the dial does. So what you can figure out is, are there specific situations where the kid's struggling more, where they're having more difficulty, so that if they need specific hearing assistive technology, maybe they need an FM system, not just at school, they need one at home. Or it could be something as simple as Johnny's having a really hard time keeping his hearing aids on when he's playing basketball. Maybe you need to get huggy aids, so everything that goes on and allows the hearing aids to stay in place, because to be honest with you, when you were seeing a 9-year-old in your office for the 4th time since basketball season started, because he keeps having his hearing aids pop out and land on the floor and get stepped on, and unfortunately the manufacturer only covers 1 incidence of loss or damage in your lifetime for free, although typically if you know people, they'll recase it. They won't put it in as a damage claim. They'll say it was a defect, the case cracked, so. But yeah, so I mean, you don't need the dial to tell you, ooh, you need to come up with a solution here. But anyway, it does help you kind of focus what kind of assistive technology might be pursuing. There's the ABLE, which is the auditory behavior in everyday life. So again, it's kind of a functional parent questionnaire, looking at the child's auditory skills in lots of everyday types of situations and activities. The SIFTR is very, very, very popular. The folks at Ivy Medical Center, which is like one of the largest cochlear implant centers in the country, actually in the world, they use the SIFTR all the time. And it's the screening instrument for targeting recognition of risk in preschool children. So they'll do some pre and post testing with kids getting cochlear implants, and it helps them decide where early interventions or preschool programs really need to focus with a particular child. So it's kind of cool. And then there's the LIFE, which is the listening inventory for education. So it's sort of like the SIFTR, but it's for older kids. And what's really neat is it has, depending on how they do, it gives you specific goals and approaches to incorporate in their IEP, which for the folks who are struggling with and dealing with writing and updating and upgrading IEPs, isn't it fun that happens a lot during your spring placement in the school system? So you get a lot of opportunity to do that. But it's great because this particular tool, if you're working with kids who have hearing loss, it's nice because based on how they do, you actually have your goals and approaches laid out for you. Okay. Something that we need to talk about that's unpleasant, but it's kind of related here because during intervention, we're often going to notice it, is the topic of abuse and neglect. So before we jump into that, do you guys have questions about treatment, direct or indirect? it's really not voodoo magic. You're gonna do a lot of the same things that you would do if the child is hearing impaired and has an articulation problem. You're still gonna use a lot of the same strategies you use with a child who can hear. You're gonna have to make some accommodations. If you're trying to facilitate language, you're gonna do a lot of the same things that you do with any other child who has a language impairment. Okay, you just have to consider their hearing impairment and their, how much auditory information are they getting, what's the quality of it, and then make some adaptations for them. Okay? Questions? Okay. Not a fun topic, but it's one that we need to talk about, and that is neglect and abuse. I haven't updated my statistics since 2010, so I probably need to do that. But in 2010, there were 3.6 million reported cases of abuse and neglect in the U.S. 3.6 million. That's the population of some states. Okay? That's a lot of kids. Of those 3.6 million cases, 1.4 million, so almost half of them, a little over a third anyway, resulted in ongoing investigation and intervention. So that's not to say that over 2 million of the cases were decided that there was nothing wrong. Pardon me, but maybe it was something where the parents needed access to services. So they didn't have insurance, they weren't taking their kid in for regular checkups, and the kids asthmatic, well, they could get them into a program and things like that. So, but roughly a third of them, there's going to be ongoing need for follow-up. Okay? 9 to 10 kids per 1,000 were affected by abuse or neglect in 2010. So that's a lot of kids. It's a lot of kids. In 2010, 3/4 of the cases were considered neglect. 15% were physical abuse, and 10% were sexual abuse. I think you probably can fairly easily know what sexual abuse is, what physical abuse is. But neglect, what's neglect? When you hear that a kid is suffering neglect, what comes to mind?
Parents that aren't doing like everything they do for their child, well, not like extravagant things, but necessary things.
Right. That there some aspect of the basics. Give me an example.
Like not hugging your kid or telling them that you love them or just being there for them.
Okay.
Food, shelter, clothing.
Yeah, the essentials, medical care, those types of things. It's not necessarily that they're not paying attention to their child, but they're, and a lot of times it's not intentional either. That's the other thing to consider. It's, dad has lost his job, mom's trying to make ends meet. They've got, a couple of kids, and they're overwhelmed. So it's not necessarily that they're evil people. It's just a situation where they get in over their heads. We as healthcare professionals are obligated to report any suspected cases of abuse or neglect. And if we don't, and there is an issue, and it's found out that we knew we're now an accessory. And frankly, it's just the right thing to do. I could not sleep at night if I thought, and I've reported parents, and I've actually had parents meet me in the parking lot afterwards, and I know it was you that turned me in. So if I saw the cigarette burn marks and, said, Sophie, I'll take a punch, I'd rather take it than have the kid.
So what do you do in the case where maybe like it is unintentional and they don't have the means?
Then they get hooked up with social services.
Oh. So is it, I guess, our duty to, I hate to say know the difference, but is it obvious? Are you gonna be able to tell the difference?
No, I mean, but that's not your job to do. That's why you report it. You report what you observe or what's reported to you. And as a speech therapist, kids tell you everything. The middle name of every kid under the age of 12 is TMI. Way too much. And so, I mean, they will. And because they trust you. You are an adult that they trust. And they're used to talking to you. So they're going to tell you everything. And you have an obligation. Morally, legally, ethically, to report it. So what's really scary is that the studies show that kids with disabilities or special needs are up to 5 times more likely than a typical child to experience neglect or abuse. Okay? Rochester Institute for the Deaf did a study, and they found that the incidence of neglect and abuse was 25% higher among children with hearing impairment than those with normal hearing. They also did a survey of undergraduates. 77%, so over 3/4 of their deaf and hard of hearing students reported some type of neglect or abuse prior to the age of 16. And yet, amongst their normal hearing peers, less than 50% of them reported that. So just be aware it's a problem, and we're on the front lines to put a stop to it, or at least to try and get people access to services. So, questions? Great. Thank you very much for showing up tonight. I know today is an unofficial holiday. A lot of you, whether legally or not,